to the diagnostics of the infection and all the problems with the epidemiology, it's a pleasure for me to now talk about the antibiotic therapy, which is probably equally challenging. I will focus only on gram-negative infections. I won't say that gram-positive infections are not important, but I think currently the biggest challenge is in the gram-negative infections. So these are my disclosures. Well, you've seen from the first speaker that indeed multi-drug resistance is a reality in every part of the world. And while I like these maps that show you how big the problem is, still you may think there's some white spots around there. But this is just because most often there is no data. So it's not like that there is no problem in these countries. So if you would have colors and real data from these countries, it would be all over it. And so don't let these figures misguide you. This is just one example for KPC and how widespread it is. But it surely depends on where you live, what pathogen is the main problem. But the funny thing is that we learned that antibiotic exposure leads to more multi-drug resistance. But the problem is that also multi-drug resistance is affecting our antibiotic use. We know, of course, we've been told to have a very low threshold for antibiotics. Professor Vincent discussed the issues with diagnosing infections, so it's difficult. We don't have the right tools to diagnose it, so we use it a lot. And when you add multi-drug resistance to it, that's even making things worse. So we use a lot of antibiotics. We use them for a long time. So a lot of our patients are exposed to antibiotics, and this is only fueling this vicious circle. Now, before I go into details, I want to stress that if you prescribe antibiotic, if you treat these patients, it's critical to do this in a concerted approach with your other colleagues in the hospital. And these are often referred to as antimicrobial stewardship programs, where you have guidelines based on your local ecology. Sometimes it may be necessary to restrict antibiotic use. You educate, you give feedback to your colleagues. But again, the multidisciplinarity is a key issue. So that is really critical. And my talk, I will discuss antibiotics and what you need to use. But when you use it in a proper context. Equally important is infection control, especially some of our most feared multi-drug resistant pathogens spread very easily. Acinetobacter is just one of them. But if you have these pathogens, you need to use the right antibiotics, no doubt, but you need to have proper infection control. And there's many ways you can do it, but especially it's important that you need to educate all healthcare workers in the ICU. It's not alone about the doctors, and probably the doctors are worse compared to nurses. But also the consultants that come into the unit, they need to be educated and not picking up a pathogen in the ICU and spreading it to the normal wards. And finally, the microbiology lab. And of course, the currently available tools are not good enough. We're doing very advanced things in the ICU, but we're still stuck with the basic approaches that have been used for decades. New techniques are becoming available. We're still looking on how we should be using them in the most optimal way, but surely this is the future. Appropriate therapy is important, and there's plenty of literature, and Professor Schuster already showed you that indeed appropriate therapy is a key issue, and also that multi-drug resistance is actually leading to less appropriate therapy. Again, fueling the use of antibiotics, of course, because we want to be sure that we cover all pathogens and we'll use a lot of antibiotics from the very start. This is from a large series, more than 1,000 patients with gram-negative bacteremia. And you can see that when multi-drug resistance was present, there was a 13-fold higher risk of not being appropriate, as you can expect, of course, and a logical consequence is using more antibiotics. And why is it important? Well, this is the vicious circle that was already referred to earlier. If you have resistant pathogens, you'll be using more broad-spectrum antibiotics in empirical treatment. This may lead, again, to more resistant organisms, more inadequacy, and you're stuck in this vicious circle. So what are our strategies? What can we do? How should we be using our antibiotics? I won't say too much about the combination therapy. I do think that in empirical therapy, especially if you live in a part of the world where there's a lot of, or even in your hospital, because there may be important differences, not only between countries or between cities, but even between hospitals in the same city. So local ecology, knowledge of your local ecology is crucial. And in these situations, it's fairly logical to have in your empirical scheme broad spectrum antibiotics covering the pathogens that you may be expecting. So if you have a lot of Pseudomonas, if you have a lot of Acinetobacter, you may need to cover these multi-drug resistant pathogens from the very start. So using multiple antibiotics will allow you to cover more pathogens and have a higher likelihood to have an appropriate therapy. For directed therapy, except the extensive drug-resistant pathogens, there's probably not a lot of use for combination therapy. The studies essentially have been negative, showing that once you have the susceptibility reports, you don't need more than one antibiotic. Of course, it does remain important to dose it appropriately. So dosing is important, and this is something that I will cover in the next 10 minutes. Because although new antibiotics are coming to the market, fortunately, the short-term solution that is using our antibiotics that we have now in a smarter way. Okay, there will be new antibiotics, but likely there will be resistance developing to these newly developed antibiotics before we know it. Maybe even before you will be using it in your own country, right? The past has learned that within a few years, there is resistance to any newly developed antibiotics. So it's crucial that we use our antibiotics in the most optimal way, a smarter use. And how can we do this? We need to think about the determinants of antimicrobial efficacy. And there's 3 elements involved. There's the microorganism, there's the host, and there's the antibiotic. And integrating all these different things into the treatment is, I think, a key strategy in treating multi-drug and extensive drug resistance. So what does this mean? We've known from a lot of studies that patients with sepsis have significant changes in the concentration of antibiotics. It may be low concentration, maybe high concentrations, depending on what is happening in your patient. Augmented renal clearance is indeed one important element, but on the other end of the spectrum, acute kidney injury or organ dysfunction may lead to higher concentrations. But overall, there's quite some variability in antibiotic concentrations, and it's very hard to tell when looking at the patient if indeed the patient is at risk of having low concentrations. But it's something to keep at the back of your mind. Of course, the drug is also important, and this is actually the only part in the equation that we have some information about. We know how these drugs work. We know how we should be using them in the optimal way, if it's an antibiotic that is time-dependent or concentration-dependent, but we rarely integrate this in our daily practice. And I think this is the key when we use these drugs for less susceptible pathogens. And it does not only apply to the drugs we've been discussing already for years. The beta-lactams are, of course, an important part of our antibiotic armamentarium, but it also applies to the older antibiotics. The funny thing is that, unfortunately, for many of these drugs like fosfomycin, colistin, the pharmacokinetic, pharmacodynamic data are quite limited, although new information is coming out, and still we need to update. We need more information on the most optimal use of these drugs. There are some limitations. For instance, therapeutic drug monitoring for these drugs is quite challenging. It's very difficult to determine the concentrations in the lab. But for what I call newer drugs, but these are drugs that we've been using for quite some time, these have been better described, And for instance, for carbapenems, prolonged infusion in order to increase the antibiotic exposure is one strategy to optimize antibiotic treatment. And the third element in the equation is the microorganism. And this is, this comes back again with the limited and probably outdated way the lab is reporting the results. The susceptibility is reported as, well, either S or R. We rarely get the MICs of a pathogen, and even the MIC may not give you all the information. But you should know that when susceptibility is reported, the S or the R is only an estimation whether a patient can, or a pathogen can be treated with a certain antibiotic when it is used at a standard dose, right? And as you can see on this figure, this is the MIC distribution for Pseudomonas aeruginosa, for meropenem. And you can see in blue is, well, anything that is susceptible is in blue, but it can be very susceptible on the left and a little bit less susceptible right in the middle, though everything in blue will be reported as susceptible. But it does not mean that, for instance, a pathogen with an MIC of 4 is not to be treated with meropenem, not with a standard dose, but maybe with an optimized and higher dose. You can still be treating these pathogens. And this is not reflected in the way the microbiology lab reports their results. So how do we do this? How do we integrate all this information for the different antibiotics? One strategy, I think, is improving early dosing. We use loading doses for many drugs. When we give sedatives, you probably will be giving a loading dose, maybe sometimes for vasopressors, for antiepileptics, I mean many drugs, but we don't do it for antibiotics. Although we know the volume of distribution is quite often increased, and it may take some time before you get into this steady state situation, if that even exists. But we don't, or we rarely do it for antibiotics, but it's fairly logical to also apply this in antibiotics, especially when you are using prolonged infusion, extended or continuous infusion. Indeed, it is critical to get adequate concentrations from the very start. There's less data available in intermittent dosing, but I do think it makes sense to give a higher dose when for the first administration. Please note that this is also relevant in acute kidney injury. Essentially, in acute kidney injury, you will, in renally excreted drugs, indeed, it may take longer before the drug leaves the body, but the first dose should not be a reduced dose. People tend often to forget this. Increasing the duration of exposure has already been mentioned, and this is just one example. This is the probability of target attainment for meropenem using different doses, different durations. And you can see, for instance, at an MIC of 2, which is still which is the breakpoint of susceptibility, still susceptible, by increasing the treatment duration and the dose from, for instance, 1 gram every 8 hours over half an hour to 2 grams every 8 hours over 3 hours, you can see a small increase in probability of target attainment. But look at the, well, reportedly resistant pathogens, the effect is much higher. And you can see that indeed an MIC of up to 8 can actually be treated by high-dose prolonged administration of meropenem. And this is a nice example of how indeed changing the dose and changing the way you administer the antibiotic allows you to treat pathogens with a higher MIC. The same applies, though, to aminoglycoside dosing. And you may still be using a standard 15 milligram per kilogram dose as in the package insert, but this will be inadequate in many situations. And we know from several studies that indeed you need higher dosing if you want to treat pathogens, and you have consider a worst case scenario. You will need 25 to 30 micrograms per kilogram, and this is a nice place where we can use TDM for efficacy, measure the concentrations, and make sure the antibiotic concentration is high enough. If it's not high enough on the first dose, you can adapt your second dose and indeed get better concentrations. In some studies, a study from Brussels actually, renal replacement therapy was used to eliminate the drug and still allow the use of high-dose amikacin with renal replacement therapy starting like 2 hours after the drug was given to get rid of the drug and allow the next dose to be given in 24 hours. Same applies to colistin. This is one of the, well, old drugs for new bugs. It did get a lot of attention, and currently the recommended dosing scheme is 9 million units as a loading dose, and about the same given every 24 hours in 2 or 3 times every day. As already mentioned, TDM looks attractive for this drug, but it's quite challenging. And as for many antibiotics, we're not sure about the most optimal target for colistin. Fosfomycin dosing, a bit problematic in terms that it's less well studied. And again, the biochemical analysis in the lab is quite challenging and difficult. So it's very hard to give any guidance at this point. And I'll give you some dosing recommendations for these different antibiotics at the end of my presentation. A new kid on the block is the nebulized antibiotics. Not exactly new, of course. We've been doing it for many drugs, many antibiotics in different situations, cystic fibrosis, just to name one of them. But it's an attractive way, especially to use our more toxic antibiotics, colistin and aminoglycoside, although you can use it for other drugs as well, such as Ceftazidime. But it allows you to get very high concentrations into the lungs without any significant systemic toxicity. And data will be out, I think, in the next 12 months on whether this is indeed, for these infections, a superior approach. Just a few words on the new drugs that are coming to the market. One of the problems in multi-drug resistant gram-negative bacteria is the beta-lactamases that are produced by the bacteria. And to be honest, I think this is making things quite complex. You know, there's different types, different classes of beta-lactamases, as you can see here, and you may not be familiar with the classes, but you've certainly heard about like NDM, KPC, the oxa enzymes, different enzymes that are present in these bacteria. There are of course, we have a few beta-lactamase inhibitors available now, clavulanic acid and tazobactam probably used most often. There's some new beta-lactamase inhibitors coming to the market. Avibactam is probably the first one that we have available now. The thing is that many of these beta-lactamase inhibitors have different characteristics. And on top of that, they're combined with different antibiotics, as you can see on the right. And so, for instance, avibactam is combined with ceftazidime, with aztreonam, ceftaroline, and this will lead to different spectrum for each of these combinations. So this will really add to the complexity we'll be having in the future and when to use what antibiotic in what situation. But again, it certainly will offer new opportunities. This is an overview of not all of the drugs, but those drugs that are in phase 2 or phase 3. As you can see, the future looks a little bit better compared to a few years ago. There's new drugs coming to the market, but it will be our challenge to find the right indication for each of these different drugs, because, as I said, none of them has actually the complete spectrum that we would like to have. So that will be very challenging. Ceftolozane tazobactam is one of the antibiotics that is currently already available for abdominal and UTI infections, dosed at 1.5 grams 3 times a day. There's a study underway using it in pneumonia. Remarkably, though, is that it's for pneumonia, the dose studied is actually twice the dose that's been approved for abdominal infections and urinary tract infections. So we'll have to see about that. Ceftazidime, avibactam, similar, although different target, and especially the KPC activity is very promising. Also, it's remarkable, most of the drugs are studied for urinary tract infections and intra-abdominal infections, whereas, of course, we'd like to use them in pneumonia primarily. And again, studies underway. So what is my recommended therapy for ESBLs? Still carbapenems. If you want to use carbapenem-sparing combination, the beta-lactamase inhibitors such as PIP-TAZ, when susceptible, is a good option. And this is where the new drugs will certainly have a role if you want to avoid carbapenem use. For CRE, it's more complex. It's combination therapy often with a backbone of colistin, tigecycline though at a higher dose, combined with a number of drugs. I'll skip the combination therapy in the sake of time, ending with Acinetobacter, which is challenging, absolutely. When it is susceptible carbapenems, absolutely. Colistin combined with other drugs when carbapenem resistance is a reality. And I'd like to end with an overview of the recommended dosing of the different drugs I've been mentioning, including a loading dose and some comments such as the use of prolonged infusion in case of carbapenems. The dosing recommendation of colistin, we've discussed this. Tigecycline, please note that this is, well, off-label use. The label is for a lower dose, but indeed there's some pharmacokinetic issues, and it's recommended to use a 200 milligram loading dose and 100 milligram if you for a daily dosing, although there's been an FDA warning suggesting not to use it in critically ill patients. Sulbactam and fosfomycin, the doses are on the slide. So I'd like to end with these messages. MDR is, well, it is around and it will stay around for quite some time. Appropriate therapy is, of course, as for other infections, a very important thing, although using our antibiotics to get there wisely is the challenge. Combination therapy, yes, depending on your local ecology, and once you know the susceptibility, de-escalating and reducing the number of antibiotics is probably the strategy that is preferred. But a PKPD optimized strategy, I think, is really, this is the area where this is most important. It's not so relevant with very susceptible E. coli, for instance, but this is where you will gain a lot. And I'd like to especially end with kind of an optimistic message that indeed it is challenging, but still we have drugs available, and we should not be fatalistic about multi-drug resistant infections. Thank you for your attention.